These are my disclosures. There we go. So I wanted to start also with a case this morning. So this is a 63-year-old who came to see me actually last week. He had gross hematuria about a year ago. It stopped. He got a CT urogram. He got a cystoscopy. They didn't find anything. Then he started having, about 8 months later, he started having more gross hematuria, clot hematuria. Came back, we repeated the CT urogram, really no family history of cancer, non-smoking. He works as a medical malpractice attorney, I always love that, and he takes amlodipine. So this is his imaging. As you can see here on the delayed images, there's clearly something within the collecting system here and over here. And the reason I wanted to start with this case is because my first thought in this patient is, yes, I have to go and do a ureteroscopy, but is this something invasive? Is this something that's gonna immediately need a nephro-U, or is this something that I could treat, ablate with laser, even if I thought it was high grade? Now, I'm not gonna show you the rest of the images, but I can tell you it doesn't look like it's locally invasive on the CT imaging, which is obviously gonna play a big role in how we're gonna treat this. Let's see. But let's talk a little bit about staging. So this was a study out of Korea, and what I liked about this study is that they actually included some of the genomics in it. And they looked at about 266 patients, and these were patients that were high grade that underwent RNU. And there's probably about 10 different nomograms out there, and what all of the nomograms have in common is that what the CT looks like, how invasive the tumor looks on CT, whether the patients have high grade, especially if they have carcinoma in situ, and, sorry, is that someone talking? Oh, sorry, so I thought someone was talking. And whether these patients have, any intratumoral heterogeneity makes a big factor in predicting whether they're invasive or not invasive. And again, that's gonna be important if you want to try to do any kidney sparing preservation with patients with high grade. So using these tools as a measure of invasiveness is actually really important. So again, CT and CIS were the biggest factors for them. What about radiomics? So radiomics is also, I think, gonna play a role, especially for upper tract, because diagnosis is sometimes so hard and staging is so hard. So this was a study that actually looked at the perirenal fat. And they were able to predict in the Kaplan-Meier curves the high risk versus low risk. And you looked at the radiomics combined with the clinical features. This out-predicted just the clinical features alone. What was interesting about the ROC curves is that the radiomics actually predicted in the short term which patients were going to be high risk versus low risk and their survival better than the combined with the clinical and the radiomics. But if you combine them both, then you could predict these patients' outcomes for up to 30 to 60 months. So I think this is also going to hopefully play a big role for us with upper tract, because sometimes diagnosis as well as staging is so difficult. What about genomics? I know we talked about this yesterday, that we really need some better biomarkers for these patients going forward. This is a study by Wesley up out of City of Hope, and there's actually 4 trials right now looking at biomarkers specifically for upper tract. One of them is looking at DNA methylation, one at cell-free DNA, circulating tumor cells, CTCs, UTCs, and urine screening DNA. So I'm excited to see out of these 4 trials what comes out, especially as far as sensitivity and specificity for finding cancer, or is it just gonna help us have prognostic factors? So what are our options for kidney sparing and ablation? So we have ablation option, including holmium laser, I call NeoYAG, or thulium. Then we have the Moses, which is a new laser that's come out, and another one called the light touch laser. There's immunotherapy with BCG and BCG Pembro. We have chemoablation for these tumors, and then there's a couple of new trials, the Enlighten trial and the STO2. So if we want to talk about RNU versus endoablation alone, and this slide is specifically for low grade, you can see that RNU versus ablation in patients with low grade, their 5-year cancer-specific survival is very comparable. So we know in this low-grade population, we really don't need to be doing RNU. We can probably do more endoablation, either with chemoablation, immunotherapy, or with laser ablation. If you want to look at endoscopic intervention or ablation versus RNU in the high-grade population, in this trial, they looked at the 5-year overall survival of high-grade, and you can see that in this group here, obviously RNU performs better in the overall survival. But in the cancer-specific survival, especially for high-grade, which is really what I wanted to look at when I was looking at this study, they were comparable RNU versus laser ablation. If you want to look at laser ablation specifically based on the type of laser, and each of the different lasers has unique properties, and I'm not going to bore the medical oncologist with all of that at the moment, but there was data that showed that the holmium laser, the neo laser, even using them combined, actually performed, well, actually the thulium laser performed better as far as the recurrence rate. So when I think about laser ablation, there are two things that are important to me. One, how fast are the patients going to recur? And two, how many of those patients are going to end up getting a radical nephroureterectomy? So in the holmium and the neo group, the recurrence rate was actually higher than with the thulium groups, but and even as far as requiring RNU, I think these were comparable between the two groups. So while the patients that got this type of laser treatment did recur more often, their need for RNU ended up being the same. And these patients, a lot of them were mixed. They were both low grade and high grade in a lot of the different studies that they looked at. So this is a little bit about some of the newer laser trials that we have. A lot of this has to do with how the laser ablates the tumor, how deep you can get the laser to penetrate, and how well you can limit its ability to affect the tissue around it. So when you have a pulse modulating laser, because of the way it sort of divides the water, it can actually decrease how it's hitting the tissue around it, and then it can penetrate a little bit deeper, but not affect so much of the tissue, and also it can coagulate better. There was a study on this pulse modulating laser. They only had about 12 patients with a 75% recurrence rate, which was pretty consistent with all the other, with the holmium, the neo laser. And then the whole point about the light touch laser, it's the wavelength again that makes the difference. This is a laser that's been used in a lot of other tissue modalities. It's a soft tissue, it has very good soft tissue penetration. And the biggest factor about this laser is it had excellent coagulation hemostasis. And you could do in-block resection, which was pretty important because when you're working ureteroscopically, if it's bleeding and you can't see, you're going to stop. You're not going to get the greatest biopsy specimens, and you're definitely not going to have a great ablation. So that was the benefit of using these two new lasers that have come out on the market. What about the TUCAD study? So the benefit of the TUCAD study was that you didn't have to pinpoint anything with a laser. You could give this IV, then use the light delivery system to activate the free radicals and see if you could actually affect the tumor. So you didn't have to worry too much about tissue penetration or bleeding in this study. This is still ongoing and they're still enrolling in this study. The last update I heard was in 2023. They had 12 patients. 9 of the patients actually completed the IPT with a 67% complete response rate and a partial response rate of about 33%. What about chemoablation? This is also something that we've been familiar with, especially for high-grade disease or CIS in patients. But again, even in these studies, how do I go back? Even in these studies, we're still seeing a high level of recurrence in these patients, and it's variable on their cancer-specific survival depending on whether these patients were low-grade or high-grade. And all of these studies here, it was a bit of a mixed bag. There were high-grade and low-grade patients. This is a study by our own Dr. O'Donnell sitting here. This was the endoluminal gemcitabine and docetaxel versus BCG and CIS. And I know you had another study that came out in 2024 just looking at the endoluminal gemcitabine and docetaxel in high-grade disease. But in this study specifically, especially because with CIS, oftentimes we find it only on cytology. It's not something we see. I think this is definitely another good immunotherapy or chemoablative option for patients. So when we looked at BCG versus gem-dosi specifically, the recurrence-free survival and then the RNU-free survival was 61% and 89% in the BCG group and 54% and 100% in the gem-dosi group. So in this study, the gem-dosi outperformed the BCG, but they did note that any installation versus percutaneous nephrostomy increased the risk of recurrence. And I actually wanted to ask you why, and you can maybe give a little later on that. Or just go ahead.
That we were forced to move from retrograde stent installation versus percutaneous because it just became logistically impossible to place little 4 French catheters up every time for each and every treatment. My partners basically squeezed me out of it because we're not go on trips, that we're not doing this anymore. So, and there was a billing issue as well. But this was relatively early in. When you look at the groups, we had like 40 patients in the retrograde and 20 in the antegrade. We're now completely antegrade, and I think there's a difference in time follow-up. So we'll see if this is a potential just statistical problem, or there is a potential that if you have a retrograde catheter in that stays in during the drip, you're decreasing the luminal size, and therefore there's more likely to be a slower transit or maybe an increased pressure, such that theoretically you might have more chemo exposure if you have something that's sort of decreasing the exit rate of the agent. Don't know. It was a surprise, and I'm not sure if it's real yet.
Thanks.
Diagnose the upper tract CIS?
We use differential barbitage cytology using 5 French Pollock catheters. After we've rinsed the bladder out completely and washed it out, we go in and using a saline squirt as we go in to prevent bladder contamination, get it all the way up to the renal pelvis. Then we do washes, they're 10 cc washes at 25, 20, 15, and 10, and then pull that all together and send it. And at the same time, and especially, that was one of their big criticisms, the majority of cases that had differential had negative bladder cytologies at the same time. So the likelihood of cross-contamination was very low.
Thanks. This is still another study. So this is Pembro with BCG in non-muscle invasive upper tract. This study is still recruiting as well. They are administering by percutaneous nephrostomy. They start the BCG about 3 weeks after the first dose of Pembro. These patients are, CIS, TA, T1 at high grade. They have confirmed selective cytology. There's no evidence of obviously metastasis, and the most important part of the study too is that the patients, this was both for bladder and upper tract, that the patients refused either cystectomy or RNU. So this is still, hopefully we'll see the data coming out from this as well. There's a new trial out. This is out of Canada with Peter Black. This is a gemcitabine suspension formula. I have looked everywhere on the internet. I cannot find what it is made of, how it works, anything. They're really very stodgy about the data. If anyone has any information, I'd be anxious to know. But they're using the gemcitabine a lot like what we did for the Olympus trial, which was, once a week for 6 weeks with smaller tumors, leaving part of the tumor intact so that you can see if it actually has any chemoablative properties. So we'll see if maybe gemcitabine in this study outperforms mitomycin. And again, that was for low-grade patients. I just wanted to also bring this up that I think, especially with patients that are high-grade, that this was sort of proof that came out of our real-world data from the UG101, that ablation with adjuvant therapy definitely outperforms just ablation alone. And so the patients that had adjuvant therapy, there was a 74% complete response versus a 39% for the chemoablative. So I think this very much mimics what we do with bladder cancer, where we ablate, cut out, treat, and then use adjuvant therapy. And what was also important about the study was that there was no difference in the recurrence-free survival based on the size, location, or how many tumors there was in the kidney. I also was hoping maybe this would spark some controversy or discussion this morning as well. So if you look at all the different guidelines, this was a paper by Ricardo Atorino in Cancers, is because we're just talking about localized disease right now. The endoscopic management was different in each of the recommendations. So for the AUA, they felt endoscopic management was reasonable in certain high-risk patients with favorable UTUC, and Dr. Taylor will tell us a little bit more about that. For low-risk masses in EAU, which is those guidelines, that means that the tumor was under 2 centimeters and no pathologic features on CT. And for the NCCN, they only recommended you do ablative therapy if patients were not suitable for RNU. So I thought there was a vast difference between the guidelines. For post-endoscopic installation on the guidelines, it's either mitomycin or BCG for the AUA, and for the EUA it was mitomycin and NCCN mitomycin. So maybe we could also talk about this, and there were some other differences, especially for muscle invasive or metastatic disease as well. So I feel upper tract is still a big blue deep hole that we're figuring out.